Welcome. My name is Dr. Jim McDonald, Medical Director of the Office of Public Health at the New York State Department of Health. Joining me today are Brian Backetson, Dr. Emily Lutterloh, Dr. Christine Egan, and Dr. Mike Ryan. We're going to be talking today about Ebola. Our objectives today, we're going to describe the history of Ebola, its clinical presentation, and risk of infection. We're going to understand current United States and New York State response to the current Ebola Sudan outbreak. We're also going to describe the usage of personal protective equipment. We're going to describe the role of hospitals and transportation and describe laboratory testing and waste management. When you think about the history, transmission, and clinical presentation of Ebola, as well as our current situation, it reminds me that Ebola was first described in 1976 near the Ebola River in the Democratic Republic of Congo. And throughout history, we've heard about multiple outbreaks with high case fatality rates. Ebola virus is just one of the filoviridae, as well as Marburg virus and Queva virus. It's important to note that Ebola has 6 species, but only the first 4 cause disease in humans. Our emphasis today is going to be on the Sudan virus disease, or the Sudan strain of Ebola virus. This is where the epidemic is occurring right now from this strain of Ebola virus. And it does have a case fatality rate historically of about 50%. We're not going to spend too much time talking about the other strains that infect humans, about the Zaire strain, or the Thai forest strain, or the other strains. Because quite frankly, we want to focus on what is the problem today, which is the Sudan strain of the Ebola virus. So I want to chat a little bit with how is Ebola transmitted. And it's really important to remember Ebola is only transmitted when people are symptomatic. Another thing to remember, it's direct contact. In other words, Ebola is spread when there's broken skin or mucous membranes in the eyes, nose, or mouth. And it has to come in contact with body fluids or blood, urine, saliva, sweat, feces, vomit, breast milk, amniotic fluid, and semen are just some of the body fluids of a person who is sick with or has died from Ebola virus disease. There is some transmission possibility from objects such as clothes, bedding, needles, or medical equipment that's contaminated with body fluids from a person who is sick with or has died from Ebola virus disease. It's also possible to get Ebola from infected fruit bats or non-human primates, and also from semen from a man who recently recovered from Ebola virus disease. That be through oral, vaginal, or anal sex. And then less likely, but does occur, is from eating bushmeat. I just want to spend a moment or two on the clinical presentation of Ebola. And although I'm going to be brief, it's just important to remember that every system can be involved. The incubation period for Ebola virus disease is 2 to 21 days, although 8 to 10 is most common. Typically, patients present initially what's called dry Ebola. There's an abrupt onset of fever or chills, aches and pains, fatigue, sore throat, loss of appetite. However, it progresses to what's commonly referred to as wet Ebola, where there's profound diarrhea, vomiting, and most notably unexplained hemorrhaging or bleeding, which can really be quite significant. Some of the clinical lab findings in a patient with Ebola. You can initially have leukopenia followed by elevation. There can be thrombocytopenia, and typically the nadir for that is day 6 to 8. An increased hematocrit as well as elevated transaminases are also seen. You also can see prolonged PT, PTT, proteinuria, elevated creatinine, and BUN. There's also electrolyte abnormalities that occur as well. I want to touch a little bit about prevention and treatment for Ebola. It's important to note there is no vaccine for Ebola Sudan, which is what's causing the current outbreak. There is a vaccine for Ebola Zaire, the strain that caused the 2014-2016 West African outbreak. The vaccine for Sudan strains are currently being tested in situ, but there is no ring vaccination after the first cases in this Ugandan outbreak, so there are some clinical trials going on. Treatment is primarily supportive, and by that what I mean is treatment is managing every system that's got a problem, and it can often require intensive care level treatment. I do want to note that there are monoclonal antibody treatments for Ebola Zaire that are out there, and as far as clinical trials, there might be some coming for Ebola Sudan. This is a situation update as of November 21st, 2022. According to the World Health Organization, at that time we had 141 confirmed cases, 55 confirmed deaths in 9 districts of Uganda. 19 healthcare workers were infected and 7 have passed away. Our recent data suggests that cases may be slowing, but it's important to remember again, these cases are being caused by the Sudan strain of Ebola. Most other Ebola outbreaks, including the large 2014 to 2016 West African outbreak, were caused by the Zaire strain. The non-government organizations usually do assist with Ebola outbreaks in Africa. In 2014 to 2016, individuals working for those organizations returned to the U.S. were at the highest risk were quarantined. In outbreaks in the Democratic Republic of Congo in 2020-21, NGOs were not on site because of safety concerns. Now over to Brian Backinson to discuss the U.S. and New York response in PUI evaluation.
Thank you, Dr. McDonald. My name is Brian Backinson. I'm the director of our Bureau of Communicable Disease Control. I want to talk a little bit about the United States and New York response and evaluation of PUIs, people who come into your office or emergency room. Travelers returning from Uganda are screened for risk and symptoms before leaving Uganda. That's the first opportunity they've had to get screened for symptoms and for risk. The CDC is funneling all passengers from Uganda into 5 U.S. airports. Those are JFK in New York, Newark in New Jersey, Dulles in Washington, D.C., Chicago O'Hare, and Atlanta Hartsfield. There are no direct flights from Uganda, and to the United States, we get about 150 travelers per day. These are going to be individuals who have had travel that's through kind of what you might think of as one transaction. We're not going to be able to capture broken travel. So travelers that, travel from Uganda to another country, perhaps Europe or Africa, stay for a couple of days and then wind up coming to the United States, they're not going to get captured through this net. They may get captured through customs, where they may go back and take a look through their passport and see where they had been within the past 21 days. But there's a possibility they may get missed this way. They also may get missed through land border crossings as well. But so again, travelers who fly to Canada and then by land to the United States may not be captured through this particular system as well. But passengers who do go to those 5 airports are screened for risk and symptoms by CDC. Now, this is their second opportunity to be getting screened for both risk and or symptoms. At JFK here in New York, if medical attention is warranted, they'll be transported to hospitals in New York City or nearby that can accept these particular patients. We at the State Health Department and the New York City Health Department get daily lists from CDC of travelers from Uganda, and working with local health departments, county health departments, we contact and monitor those individuals for up to 21 days. So this is now the third particular screening that these individuals have. We're really trying to make sure that, if anyone does come back to the United States and is either high risk or has symptoms of Ebola, that we'll be able to capture them through these 3 particular screening methods. So this is a table that sort of shows these high-risk travelers in 3 particular categories. The first we have is having just been to Uganda, and there they would get this risk assessment up to 3 times, like we talked about on the previous slide. They all get educated on symptoms and actions to take if ill. We want to have people who have been to Uganda to not just show up at a medical provider. We want to tell them where to go and how to coordinate this so we can minimize whatever anxiety or chaos might be happening in a particular medical facility. They'll be monitored at least weekly, up to 21 days, and there's no movement restrictions on just somebody who has been to Uganda. We will try and coordinate their travel if they do have travel. If you've been to an outbreak district or an area in Uganda, you get that same 3-time risk assessment. You're educated again on symptoms and actions to take if you become ill. You're monitored twice a week. There's no movement restrictions, but we would like to coordinate your travel. And then if there's an individual who reports high risk exposure, again, they have that same risk assessment of any traveler, that same education. We monitor them every single day, in some cases via video, and we will put them into quarantine. So there are movement restrictions and no travels allowed. So people that have the highest risk exposure, and typically this would be individuals in the medical community, people who have worked for non-governmental organizations, who have been in Uganda working directly with patients. These are the people that would be in that high risk exposure group. So if an individual does present with symptoms, does that person warrant concern or testing? Do they meet the definition of what a person under investigation actually is? What we're looking for here are people that have signs and symptoms that are consistent with EBD, and an epidemiologic risk factor within 21 days before symptom onset. That includes travel to an outbreak area with EVD cases, and it includes those high-risk exposure criteria that Dr. McDonald had talked a little bit about earlier. Those are the people that would meet the definition for a person under investigation. The signs and symptoms, again, that we're looking for, just to reiterate, would be fever, aches and pains, such as severe headache or muscle and joint pain, weakness and fatigue, sore throat, loss of appetite, GI symptoms, including abdominal pain, diarrhea, and vomiting, unexplained hemorrhaging, bleeding or bruising, red eyes, skin rash, and even something like hiccups has been known to be common with regards to Ebola. When someone does come in and we want you to evaluate them for PUI status, we want you to obtain a travel history from patients with symptoms of EVD. It's good to obtain a travel history of any patient who winds up coming in, but particularly here with EVD, we want to ask if they've been to an area with active Ebola virus outbreak in the past 21 days. We want to ask about these high-risk exposures. Did you care for or been in close contact with someone or suspected or confirmed to have EVD? That includes just being in contact with contaminated objects like bedding or clothing or needles. If so, we also want to know, did they wear and use PPE appropriately? While in Uganda, did they participate in funeral rituals or touch dead bodies? Had they maybe had contact with semen from a man who's recovered from EVD? While they were in Uganda, did they have any contact with animals, domestic or wild, particularly eating bushmeat? And all these high-risk exposures are the most common ways that people wind up getting Ebola transmission. These are the districts where we've had Ebola transmission taking place. It's a little bit of a moving target. CDC posts this particular map on their website, which you can see here at the link you can see here off to the right. And the number of districts where we have had Ebola transmission taking place has changed a little bit over the past several months. The main thing we see is there are 9 districts where Ebola transmission is taking place. Most of these are to the west of the capital, but there are other areas in Uganda where we are seeing cases. Some of these districts have had more cases than others, but in general, it's a smart thing to do to bookmark this particular map, this particular website, to be able to take a look and see if people had traveled to these particular areas. So EVD is extremely unlikely unless the patient had travel history to currently affected areas and had had high-risk exposures. Ebola is difficult to get. We want you to proceed with routine care of the patient, including diagnostics and treatment. We don't want individuals to miss out on treatment because of concern about Ebola. Routine procedures for infection prevention and control can be found at these particular websites. There's established procedures for public health reporting, which we'll get into a little bit later on. Basically, we want you to contact your county health department, those of us at New York State or New York City health departments, and stay up to date on areas that are currently affected. Having all these things handy and be able to check on them is a very, very good thing to be able to do. But the main thing I think we really want you to do as providers is to be able to reach out to public health so that we can kind of help guide you through this particular process. No matter what, we want you to isolate the patient. If you think that someone has possible EVD, we want you to isolate the patient, place the patient in a room by themselves, preferably one with a private bathroom or a covered bedside commode with the door closed. If the facility has an airborne isolation and infection room, the room should be prioritized for these particular patients. Aerosol generating procedures should be done in that particular room whenever feasible. A standard room can be used. Healthcare providers should use appropriate PPE. We want to use only essential healthcare workers trained in their roles for patient care. We want to minimize the number of individuals that go in and work with this particular patient. And we want you to keep a log of everyone who enters and leaves the patient's room. If, again, God forbid, this particular individual does wind up having EVD, then we would be looking to contacts for those individuals. So we want to keep them at a minimum and know who they are. If during the course of your evaluation you still think that this indicates a possible Ebola virus disease, you want to notify the facility infection prevention and control program as soon as possible. They can help you out with regards to guidance, but in general, you want to use appropriate PPE. You want to have good hand hygiene. You want to avoid aerosol generating procedures as much as possible. You want to use dedicated equipment, preferably disposable if possible. Clean and disinfect non-dedicated, non-disposable equipment according to manufacturer's directions. You want to try and limit the use of needles and sharps, performing essential phlebotomy and lab testing only, use care and handling and disposal of those sharps, perform effective and appropriate cleaning and disinfection, adhere to safe infection practices, evaluate the duration of infection control program precautions on a case-by-case basis. How long can you keep someone doing this particular type of infection control that you're doing? Monitor and manage potentially exposed personnel and manage visitation. Again, we can help you with all these things if you contact us during the course of this particular evaluation. If you don't know whether or not someone is a PUI or not, and like I've said, even if you do have someone that you believe is a PUI, we want you to contact public health for assistance. These are some ways that you can do that. New York City providers can contact their provider access line. Outside of New York City, please contact your local health department. If you can't reach your local health department, and by local health department, I typically mean county health department. If you're unable to reach that health department where the patient resides, please contact us at the Bureau of Communicable Disease Control, either during business hours or our duty officer line during evenings, weekends, and holidays. And again, here's a couple of examples. A patient who reports travel to an affected area, has no reported risk factors, but presents with symptoms that might be EVD. Again, we can talk you through this and try and decide whether or not this is something that might be worth testing or whether or not we want to evaluate them otherwise. So far to date, having started this in early October, we've screened over 350 travelers so far. All have been low risk. We haven't had any who have been PUIs. About on any given day here in New York, we have about 50 people that are being monitored in the state and in New York City. And just a little bit of history with the large outbreak that we had from 2014 to 2016, there were over 6,200 travelers that were evaluated and monitored. There were only 25 or so that were high risk. All of those were from non-governmental organizations that we knew were coming into New York in advance. We had them in quarantine and we managed them appropriately. And we only had one that was a case. Again, the likelihood of someone being an Ebola case who had just had travel to Uganda is really, really, really quite low. And the last thing I think I want to talk on in this section is just how large Africa is and where Uganda fits into the course of this. You see on the left-hand side of this particular screen, this is the silhouette of Uganda compared to the New England and New York. And on the right-hand side of this, you see Uganda highlighted within the course of Africa, and you see the United States there in Africa as well. I am one of the people that gets calls in the middle of the night from people wanting to know about whether or not people should be evaluated. And one of the things that we often get are people just who had traveled to Africa somewhere and whether or not we should evaluate them. Again, remember that we're really most concerned with people who had traveled to just small parts of Uganda. And again, Uganda is quite large, Africa is quite large, and understanding that people are concerned about not wanting to put other individuals at risk. But again, this is just another way, I think, of showing that risk is smaller than we actually think. And now I'm going to hand it over to Dr. Emily Litterlow to talk a little bit about PPE, expectations of hospitals, and transportation.
Thank you, Brian. My name's Emily Litterlow. I'm the director of our Division of Epidemiology here at the New York State Department of Health. And today I'm going to talk about PPE, expectations of hospitals, and transportation. So the first slide you see here is a summary of healthcare personnel PPE recommendations. And there are a few things I want you to notice about this slide. Both columns are for PPE to be used with patients under investigation, or PUIs. Now, ideally, you will know ahead of time if a patient presents whether they are a PUI or not. But we understand that there may be situations when a patient shows up and you're still in conversations with the local health department or us at the state about whether they need to be considered a PUI. These PPE recommendations also could be used for those patients if there is a lot of suspicion that they might end up being a PUI. This slide shows some links to videos that can be used to show how different combinations of personal protective equipment can be used. They show the donning and doffing for whatever combination is used in your facility. You can see there's one which is an N95 respirator and a gown, all the way up to the type of PPE that would be used in a special pathogens treatment center where you have a trained observer and perhaps a PAPR and a fluid-resistant gown and booties and all of that special PPE. This slide just is another slide giving you some guidance for PPE use and some references. The first one is guidance for clinically stable PUIs who do not have bleeding, vomiting, or diarrhea. So this would correspond to the first column on the slide a few slides ago that I showed you. And then the second one, number 2 here, is guidance for confirmed Ebola virus disease patients or PUIs who are clinically unstable or who have bleeding, vomiting, or diarrhea. And this would correspond to the second column on the slide that I showed you before. Now let's talk a little bit about expectations for general hospitals. The first thing is that we encourage all frontline hospitals to review the health advisory that the State Department of Health issued on October 27th of this year about Ebola virus disease in Uganda. The advisory includes readiness activities and policies and procedures. It replaces previous guidance that you may have had about Ebola and discusses issues surrounding signage and communication, training. There's more about PPE in here, patient registration, screening, initial and ongoing care, exposure logs, medical waste and decontamination, and transportation. And I'm going to talk a little bit more about some of these things today. What do you do if you have a patient present with suspected Ebola virus disease? And I know the previous speaker has gone into this a little bit. I'm just going to summarize here what the expectations are for most frontline hospitals. On this slide, we have listed the clinical criteria, which are fever, and one or more of these additional symptoms listed here, and then also epidemiologic risk factors, and that might be contact with blood or other body fluids from a patient known or suspected to have EVD, residence in or travel to an area where EVD transmission is active, or direct handling of certain types of animals from disease endemic areas. Now, even with these clinical criteria and epidemiologic risk factors, we understand that sometimes it can be kind of hard to determine if a patient should be considered to be a PUI or not. So that's what we're here for to help with. Once you do identify a patient as potentially ill with EVD, either someone who is to be considered a PUI or someone that you strongly suspect will be considered a PUI, the patient should be immediately isolated, and traffic by other patients or other staff near the room or hallway where the patient's located should be restricted. The patient should be given a surgical mask and demonstrated how to use it. And then, of course, you want to minimize the number of staff who interact with the patient and also maintain a log of all staff contacts. Follow standard droplet and contact infection control precautions for all patient interactions unless what you have learned so far about the patient or your discussions with the local health department or the state have determined that additional PPE is needed. And then, of course, wear that appropriate PPE upon entry into the patient's room. We've mentioned a little bit before about the importance of consultation with the local health department. And in the unlikely event that a patient does show up in your hospital and you haven't been warned ahead of time, or perhaps the timing is such that the consultation is just now taking place, be prepared to describe the patient's risk factors in travel, including dates and locations of travel, any contact with sick or deceased people, or healthcare facilities or animals, and this is all in areas with ongoing EVD transmission. And then describe the patient's presenting symptoms, sign, and duration of illness. And again, I want to emphasize that we are monitoring these patients, so and they are educated about what to do if they get sick. So ideally, in almost all cases, all of this should be known even before they present to your hospital. But we want you to know what to do just in case things don't happen in the ideal way. Once you have all of that information, you can expect to discuss the case and possible recommendations for testing, and then also get information on the need to refer the patient to a special pathogen assessment and treatment center or not for further workup and testing. And then you will also get assistance on arranging patient transport if that's needed. We know that emergency medical services agencies may be called upon to transport a patient, for example, from EVD screening sites like at airports, from the individual's place of residence, or from a frontline hospital to a special pathogen treatment center. And our Bureau of Emergency Medical Services and Trauma Systems has provided guidance to EMS agencies about the expectation for prevention and control of EVD. This went out in, I believe, 2021. All EMS agencies are expected to have plans and policies and procedures in place so that they can safely transport these individuals in a timely way. And those plans should include things like identification, isolation, medical evaluation, training, monitoring of personnel, decontamination and medical waste disposal, and then transportation and treatment of the patients. Also, the New York State designated special pathogen treatment centers are expected to maintain agreements with EMS transport services so that they have an EMS agency already in place to transport these patients. And the agreement is supposed to cover transportation of patients from a frontline hospital to the Special Pathogen Treatment Center, and also from a Special Pathogen Treatment Center to the Region 2 Special Pathogen Treatment Center, which is Bellevue. Frontline hospitals should coordinate the patient transportation with the receiving Special Pathogen Treatment Center, and this is something that we at the state and probably also the local health department are likely to be involved with too, so you're not going to be on your own here. There also is an HHS air transportation service that are available by request through FEMA Region 2 if that is needed. My last slide here shows the New York State designated special pathogen treatment centers. As you can see, they are around the state. We have some down in the metropolitan area, and then we have some upstate. This is the list of special pathogen treatment centers that are currently open and available to receive patients. We strongly encourage you to know your local special pathogen treatment center and work with them when you're developing plans for your own facility. And with that, I will turn it over to Dr. Christina Egan to talk about laboratory testing.
Thank you, Dr. Lutterlow. My name is Christina Egan. I'm Deputy Director of the Division of Infectious Diseases at Wadsworth Center, and I direct the Biodefense Laboratory. I'm going to be talking today about laboratory testing for Ebola virus patients. There are 28 public health laboratories that can perform Sudan Ebola virus testing in the U.S. In New York, the New York City Public Health Laboratory and the Wadsworth Center have the capability to test for Sudan Ebola virus. In addition, the Bellevue Special Pathogen Center also can perform Sudan Ebola virus testing. Should the need arise, there is additional regional capacity in the Northeast in state public health laboratories, as well as throughout the United States in the Laboratory Response Network. Should the need arise for testing for Sudan Ebola virus, 2 lavender whole top blood specimens with EDTA should be sent to the public health laboratory. The minimum volume for adults should be 4 mL per whole blood and 1 mL for pediatric samples. Specimen tubes should be decontaminated before packaging and transport to the public health laboratory. In accordance with DOT, Category A shippers need to be used for transport to the public health lab for Ebola testing. Remember, if collecting a specimen that is less than 72 hours from symptom onset, an additional specimen that is taken 3 to 4 days after symptom onset should be also sent to the public health laboratory for Sudan Ebola virus testing. Specimens should be sent refrigerated on cold packs to the Wadsworth Center or the New York City Public Health Laboratory. What can hospital laboratories do to prepare should an Ebola virus patient arrive at your facility? First, the laboratory should review and update the biohazard risk assessment and all laboratory protocols. Every clinical laboratory permitted by the New York State Wadsworth Center Clinical Laboratory Evaluation Program has a biohazard risk assessment. These risk assessments should be updated annually and when new testing is performed by the laboratory. Category A infectious substance shippers should be obtained by your laboratory to transport specimens for Sudan Ebola virus testing to Wadsworth Center or the New York City Public Health Laboratory. Finally, hospital laboratories should ensure that laboratory staff are trained and certified to package and ship specimens for Sudan Ebola virus testing. There are plenty of training opportunities that are available through the New York City Public Health Laboratory, Wadsworth Center, and CDC. Hospital laboratories should be prepared to perform limited laboratory testing for patient evaluation. We now have experience since the 2014 Zaire Ebola virus outbreak that laboratory testing can be performed safely in clinical BSL-2 laboratories. This includes experience with PUIs, confirmed Ebola virus patients, as well as other patients with hemorrhagic fever viruses that have been safely tested in our hospital laboratories. In addition, laboratory instrumentation should be reviewed as part of the risk assessment, and laboratories should develop decontamination protocols based on manufacturers' recommendations. Laboratories should consult with the manufacturer's instructions or contact the manufacturers directly regarding the specific equipment that you are using in the laboratory. For further information regarding laboratory testing, you can visit the New York City Department of Health Mental Hygiene or the New York State Department of Health Ebola virus webpage. I would like to introduce Dr. Michael Ryan, who will be discussing waste management.
Thank you, Dr. Egan. Again, my name is Michael Ryan. I'm the Associate Director of Regulatory Affairs at the Wadsworth Center. One of the areas that we provide regulatory oversight for is the handling and treatment of regulated medical waste in hospitals, clinical laboratories, diagnostic and treatment centers, and residential healthcare facilities. So today I want to discuss two areas, the waste management plan that hospitals are required to have in place and how Ebola virus disease and the handling of medical waste related to Ebola will impact your waste management plan. And I would also like to discuss how Ebola is impacting the treatment of medical waste, and for any hospital that is treating medical waste on site, how that might impact you as well. So Ebola has had a really significant impact on the management of regulated medical waste. There are special considerations for handling waste generated during patient care. There are special requirements for the packaging of Ebola medical waste that have been established by the U.S. Department of Transportation at the federal level. There are special permits that are required to transport Ebola medical waste, and those requirements have been established both by the U.S. Department of Transportation and the New York State Department of Environmental Conservation. In addition, the way Ebola waste is packaged, it will impact treatment when using an autoclave. If you are treating medical waste that has Ebola contamination from treatment of a patient, you need to look at your protocols to make sure that those protocols will work for the type of waste that you're managing, and that has to be approved by the New York State Department of Health. So the first thing I would like to discuss is the waste management plan. Waste management plan is the plan that is used by a hospital to establish policies and procedures for the handling of medical waste. It's going to be important for hospitals to review your current waste management plan, ensure that there's protocols in place for management of medical waste when you have a suspected or confirmed case of Ebola virus disease. So what is a waste management plan? In general, a waste management plan describes the kinds of waste that is being generated, the methods for treatment or disposal, policies and procedures that are in place to safely handle and transport the waste within the facility from the point of generation to where it is either stored or treated. It also discusses and describes how it's stored, those storage areas and requirements for storage, and includes information about contacts of persons responsible for monitoring compliance. So every hospital is required in accordance with our regulations to have a waste management plan. So I just wanted to discuss today some considerations for an Ebola virus disease waste management plan. If you consider the possibility of having an Ebola virus disease patient, you need to make sure that you describe within the waste management plan for Ebola the types of waste that would be generated during the care of a suspected or confirmed Ebola virus disease patient. Now, there's a number of considerations you need to think about when you describe how your Ebola medical waste will be packaged. This includes procedures that are consistent with U.S. Department of Transportation packaging requirements for transportation of untreated Category A medical waste. There are significant differences in packaging of Category A waste compared to normal regulated medical waste. And it's important that your facility should consult with your waste management company that you're working with to confirm that appropriate protocols are being used. Your procedures should also contain information detailing where each step of the packaging is being performed. For example, you'll have waste generated in a patient room, the laboratory. If there's waste being generated in a patient room, and then there's an anteroom where the waste is being held, warm or cold areas, all of these things need to be described in your waste management plan. And it's highly recommended that waste be double bagged in accordance with the U.S. Department of Transportation requirements in hot areas and then transferred to a warmer or cold area for packaging into a Category A barrel. Other things to consider regarding packaging. There should be procedures within your waste management plan describing the types of personal protective equipment that is used for packaging and how you dispose of that PPE. If you are dealing with liquid waste, how will that be packaged? You should include procedures for packaging of liquid waste. And if a solidifier is used, what are the protocols that are used to solidify that liquid and how is it packaged? If you're doing any pre-treatment of a liquid before it's disposed in the sewer, these protocols need to be included. In addition, you should have instructions on how to handle sharps. You have to make sure that the sharps container is FDA cleared for sharps disposal, that it's securely closed in accordance with the manufacturer's instructions to prevent leaks and punctures, and that should be placed into an inner bag that is then sent for packaging into a Category A barrel. Other aspects of your waste management plan that you need to consider are policies and procedures for the transport of Ebola waste from the point of generation to the point of storage and disposal. So if you think about points of generation, that could include a patient room. You should describe the flow of that waste from that patient room within the unit, any waste that is generated in a testing laboratory, the emergency department, or outpatient settings. You should also describe where the waste will be stored, the length of time it will be stored, and the capacity of that storage area, and information pertaining to ventilation and environmental control. Again, you need to think of this in terms of the patient rooms, the testing labs, the emergency department, outpatient settings, and those areas where waste is stored for a long period of time. You should also include information on who will transport any Ebola medical waste, especially if it's being treated off-site, including the name and contact information of the company and verification that the waste hauler holds appropriate approvals from the New York State Department of Environmental Conservation and the U.S. Department of Transportation. You should also provide information on who will transport any Ebola medical waste for disposal off-site, and provide names and contact information of staff responsible for monitoring the compliance plan that is described in your waste management plan. So the next area that I'm going to cover is treatment of Ebola medical waste on site. Our regulations that we are responsible for, Part 70, include requirements for autoclaves and what we refer to as alternative treatment systems that are used to treat medical waste. Some hospitals are treating medical waste on site, and if they are treating medical waste on site and they are considering treating any Ebola virus disease regulated medical waste using an autoclave or an alternative system, you need to ensure that you have the appropriate approvals from us here at Wadsworth Center prior to treating any of that medical waste. You must have a written agreement with a disposal facility that is willing to accept any of that treated Ebola virus disease medical waste. So a hospital or a clinical laboratory that uses an autoclave to treat medical waste, when you start thinking about Ebola medical waste, you have to ensure that the autoclave is properly validated for the types of waste and the way it's packaged. Because of the more stringent packaging requirements, the normal autoclave procedures may not be effective in treating that waste. Also, we have situations where suction canisters might not be effectively treated using normal operating procedures for an autoclave. So a New York State Department of Health approved operation plan designed to promote safe and effective operation of the autoclave is required. And the operation plans are basically the policies and procedures that are used for a facility's operation of an on-site autoclave. And we have additional information that can be found at the link below at our website on the Wadsworth Center website. So I just want to bring up requirements for autoclaves, and the CDC Ebola website includes information on survivability of Ebola virus and medical waste and includes suggested autoclave operating parameters. I just want everyone to be aware that those suggested operating parameters are less stringent than is what is currently required by regulation by the New York State Department of Health. Our regulations, and I've included the specific sections of those regulations, describe the generally accepted and alternative operating parameters for autoclave used to treat regulated medical waste in New York State. We have additional details that will be available on our Ebola medical waste guidance that will be posted on our New York State Department of Health Ebola website, so you can look for details there. So if a facility operates an autoclave using operating parameters other than those that are described within our regulations, that changed procedure must be approved by the New York State Department of Health, and it becomes an alternative treatment technology. So I just want to, emphasize that any changes in normal operating procedures of an autoclave need to be approved as an alternative system by the Department of Health. And again, we have additional details at the link below. The information within this presentation, I have a number of links in the resources section of this presentation, so be sure to take a look at those links. I want to thank you for your attention on this matter, and I would like to turn it over to Dr. McDonald. Thank you.
Thank you, Dr. Ryan. I'd like to spend just a few moments now talking about some resources as we get to the end of our webinar today. We did do a New York State Health Advisory, October 27th. We have the link posted there for your review. It does replace and supplant any Ebola-specific guidance previously issued by the department, including the emergency orders that were issued in response to the 2014 and 2015 outbreak. This webpage is full of some useful resources. It's broken down to generally what to know for providers and what to know for just anyone who's quite frankly curious. Did put the link to this webpage at the bottom here. I think you'll find it worth your while just to actually scroll through the provider section in particular. You'll find the resources we discussed today and just some other little tidbits about Ebola that you might find interesting. Our last slide today just covers some references and resources regarding waste management. A lot of these links are there just for you as you have to reference documents in the future. Matters recurring to solid waste, special permits, medical waste, just putting all these links in one place for you, we thought might be helpful. I want to thank you for listening to our webinar today on Ebola. Hope you've enjoyed our presentation. I want to thank Mike Wren for helping us put this all together. I'm Dr. Jim McDonald, Medical Director of the Office of Public Health.